All right. Good afternoon, everyone. Thank you for joining us. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. Thank you for joining us for this webinar on creating a culture of quality through PCMH. LRHA is happy to host this webinar presented by Kristen Ogden with the compliance team. This webinar will provide an overview of the patient-centered medical home model to improve patient outcomes. This webinar is being recorded and will be available along with a copy of the slides on the webinar recordings page of our website. I will drop a direct link to the relevant page in the chat. Your lines are muted to prevent background noise. You can enter any questions you may have either in the chat or in the Q&A box throughout, and we'll try to take those questions as they come up. After the webinar, you should automatically get a survey open in your internet browser. We do ask that you please complete that survey. It's a very short survey, but it does help us to continue to improve our future events and identify future education topics that you guys might need. So with that, I would like to welcome Kristen Ogden. Kristen is the Director of Quality Improvement with the compliance team. She was brought onto the team from an organization in Missouri where she was the Director of Clinic Quality and Accreditation for 12 rural health clinics, among many other titles, for 15 years. She found a passion for rural health and recognizes the need for advancing access for these communities. Kristen was raised in a small rural community and personally understands the barriers to resources for healthcare and is passionate about making a change to impact these barriers. Her experience as a nurse leader has fueled her desire to improve quality care and patient outcomes to more rural areas beyond her home state. And she is a graduate from Lester E. Cox College of Nursing in Springfield, Missouri. Thank you so much, Kristen, for being here, and I'm going to hand it off to you.
Wonderful. Thank you so much, Danae, and thank you all for listening in. And for those of you that couldn't join us live today, hopefully you get an opportunity. I guess if you're listening to this, you've had an opportunity to log on to the recording. I really appreciate the opportunity to present to you guys. I've had a lot of interest recently for PCMH in Louisiana. I think there's a lot of movement happening with the payers and different things moving towards the patient-centered medical home model. So I want to elaborate just a little bit on my background so you guys know my relevance in your world and where I came from. I'm not just a random person that's speaking on PCMH that didn't live the PCMH life. So like Danae said in my introduction, I came from a clinic in Southwest Missouri, actually a whole hospital system, and we had 12 rural health clinics and 3 other clinics that were not rural health clinics. And I did clinic quality and accreditation and was the clinic administrator for the rural health clinics. So in Missouri, there's an excellent payment model for patient-centered medical home for very good reasons, and you'll learn those reasons as we move along this presentation today. And so it was critical for us to become patient-centered medical homes in all of our clinics. We started with a larger organization. I'll just say we started with NCQA, and it's excellent. It's a great program. But what I found was, and as I talked to other clinics like you guys out there, what I found in my clinics was that we just didn't have the bandwidth, we didn't have the technology, we didn't have the data analytics team to sustain that model. And so one day I was at NRHA in Kansas City, and I just happened to listen to Kate Hill. A lot of you probably know Kate with the compliance team. She was talking on RHC, and then she started talking about their patient-centered medical home model. And it was like I heard a choir of angels singing. I didn't realize there were other options out there available for PCMH. And so I talked to her, and within a year or less, probably more like 9 months, we had transitioned all of our clinics from NCQA for PCMH into the compliance team, and we actually use them for our rural health clinic accreditation as well. So it was an excellent bundle, and it changed our lives, honestly. It really removed a lot of check boxes that we had to check during documentation. It removed a bunch of reports and data-driven patient care, and it really turned the focus back on the patient. So that's how I kind of became acquainted with Kate and the compliance team, was utilizing their product. Well, after our clinics became accredited, Kate would call me every once in a while to help her kind of present on PCMH for groups like yours. So she would call and say, "Hey, Kristen, I've got a group on the line, I would love for you to tell them a little bit about your experience with the compliance team and the patient center medical home and how it transitioned how it transformed and the culture of your practices. So I would do that. And then she finally called me one day and said, hey, we really, really think this would be a great thing for our company. Why don't you come work for us? So I was like, man, I get to talk about PCMH all day. That'd be great. So this is what I do now. I help clinics transition into more of a quality based practice versus that fee for service focus, that volume focus. We really start focusing on what matters most to the patient. And so it is a little bit of a culture shift, but I think it adds so much value to your practice, and it also increases, we're going to talk more about this, but patient satisfaction and staff satisfaction. So today, by the time we finish, hopefully you guys will have a little bit better understanding about what is quality care and how can you improve the quality in your clinic, understanding the patient-centered medical home model, and then identify ways to stay current in this ever-changing world, this train of value-based that we're trying to jump on. So those are the goals today. Also, I would love for you guys to please feel free just to jump in with questions. I've asked Danae to keep an eye on the chat box for me. If you have any questions or just comments, or I may ask questions. So I know I can't hear any of you or see any of you, but if you do have an answer or a comment that you'd like to make, I'd love for that to be entered into the chat. I'm way more happy whenever I've got some interruptions and some interaction, so feel free to do so. So what is quality? You guys probably really know what quality is. It's the standard of something as measured against other things of a similar kind. So really the degree of excellence of something, the degree of excellence. So what does that mean? Better results, better care, better outcomes, smarter spending, so lower cost for patients and healthier populations. And all in all, that's what the payers want, and that's what our patients want. That's what we want for our patients. So I learned a really cool new word. It's lagniappe, and it is a Cajun French word, and it means above and beyond measure, a gift given to a customer by a merchant at the time of purchase or service. So that's really what we want for all of our patients, right? We want to give them that extra layer of love, of healthcare, of services. And I think that's what PCMH really does, is it provides the icing on the cake, Okay, so with that being said, CMS does have a vision, and they would like for, equitable outcomes through high quality, affordable, person-centered care. And how are they going to measure that? Well, by 2030, they want all Medicare beneficiaries and a vast majority of Medicaid beneficiaries to be an accountable care relationship. And so PCMH really is that accountable care value over volume relationship. So there's lots of ways, and hopefully of these things that we talk about today, you guys will have a few takeaways and things that you can do, with your practice right away. First thing we're going to talk about, of course, is that patient-centered medical home model and what it means. We're going to talk about chronic care management, how to participate in those payer incentives that are available out there, measuring quality improvement, huddling with your team prior to patient care in the mornings or maybe over lunch, and then performing wellness visits. So we're going to touch on all of those things today. So as I talk about these things, I'm sure you're already in your head thinking about some challenges that you have and some barriers to this culture shift. So I would love for you guys to type in the chat some of the challenges that you foresee. I will tell you right away, the biggest challenge that we had in the beginning with this culture shift, because change is hard, it really truly is, it's very hard, was buy-in from our staff and our providers. So getting them to understand the importance and the outcomes and how it will benefit their practice and their day-to-day tasks and the things that they do is important. Technology, Danae, before we actually went live, we were talking about some of the different challenges. And obviously, I'm sure as a rural health clinic, not all of you just have money coming out of your ears, right? So EHR can always be a big challenge. Lack of real-time data that you're getting, staffing shortages, that's a national issue right now. So I know that there are a lot of staffing and challenges out there that when you start thinking about these transitions and these changes. So if any of you like to share any other ones that you're thinking of, I would love to hear those. So some patient-centered medical home programs really can be, and I experienced this firsthand. In fact, whenever I first started doing PCMH with the larger company, with NCQA, again, it had nothing to do with maybe, how they had written the standards, but I'm pretty sure that in the 2 years that we worked on our accreditation for NCQA, I lost about 10 years of my life and maybe 30% of my hair. It was very stressful, very labor intensive and data centered, and we just didn't have great data at our fingertips. So we really think that anything taking you away from that patient care is you're going in the wrong direction. We want the patient to be at the center of your focus. And efficiency in daily operations allows providers to concentrate really on what matters most to the patient and not about clicking those check boxes in your EMR. So what is PCMH? It's a model of care. It's a set of standards that you're held to that focuses on care coordination, follow up with those patients, timely communication, providing the right care at the right time at the right place, prevention over, being proactive versus reactive, prevention versus just acute illness treatment, whole person care. So are we looking into that person's life after they leave the four walls of our clinic and considering the things that could be barriers to their healthcare? So for instance, I'm sure that there are mothers out there that need to have mammograms, but their main focus right now is to feed their kids. So how can we help them with some of those social determinants of health so that they are able to focus on their health care? So those are really important aspects of patient-centered medical home, and those are the changes and the focus around the standards. Again, things change so hard, but things don't get better by being left alone. This is kind of a silly analogy, but it made so much sense to me. I was listening to a speaker, I think it was a TED Talk or something, about how if pencils had feelings, how painful it would be, because for them to perform and for them to function, they have to be sharpened by razors, right? So by that sharpener. So, we have to continue to sharpen our skills and to learn new things and to transform so that we can perform better for our patients. So this is a really brief overview of the patient-centered medical home standards. I will tell you that if you are one of our RHCs, so if you get your RHC accreditation through the compliance team, you really simply only have 8 standards to focus on to become a patient-centered medical home. It's as easy as that. However, you don't have to be one of our RHCs. You don't even have to be an RHC. Any clinic, any practice can become a patient-centered medical home. But the simplest path to that would be if you are one of our RHCs. So we will go through each of these, but just kind of a snapshot to let you know, really, this is the gist of it. Okay, so the first one is talking about team-based coordinated care. And there's a lot of components that go into this, of course. But one thing that I want to emphasize is, whose team are we talking about? Are we talking about our receptionist and our MA and our provider? Of course we are, of course. But we think you need to change your thinking just a little bit whenever you think about the patient's team. It's who's on the patient's team. That could be their caregiver. It could be social community resources. It could be behavioral health people that see them, their cardiologist or their endocrinologist. So it's really about who's on that patient's team and how are we collaborating and coordinating care across all of their healthcare needs. So thinking about that a little bit differently than just who's on your team in your clinic. Follow-up is a big thing. We're going to talk about that a little bit more, but care coordination is so important to improve patients' engagement and to improve, I need to move this just a little bit. I'm blocking my own view here. So when care is coordinated well, the patient and his or her doctors or team, they communicate with one another so that everyone has the information they need. So there's not gaps in care or maybe duplication of services. Care coordination programs can improve patients' experiences with the healthcare system and their health outcomes, as well as reduce wasteful spending in the long run. One thing that I also want to mention, this care coordination, whenever we start getting it, because we got into nursing, we got into healthcare to help people. So whenever you start digging in a little bit deeper and helping patients a little more on a personal level and finding out what matters most to them, it can be so much more rewarding as well. So when does care need to be coordinated? I really like this busy. It's a very busy graphic, but it explains it very well. There are so many opportunities for care coordination. Follow up after discharge from the emergency room or an inpatient facility. Care between PCPs and specialists. So like I said, if the PCP refers to a cardiologist, are they communicating so that one's not undoing something that the other just did, or not duplicating services? Transitions between home and facilities. This is so important when patients are discharged from the hospital, or when maybe they're going into a nursing rehab or a skilled unit or a swing bed unit. Then how are we communicating, and how is that care being coordinated across all of those aspects? Oh my goodness, so sorry. Let me start over. That's a hard one. When social services need to be coordinated. So again, we think about maybe a patient doesn't have transportation to get to and from the pharmacy or their provider's office. Are we helping with those types of things? Maybe they don't feel safe in their home. After labs and diagnostic screenings. So we really want to know that you're communicating with patients after they've had any kind of lab tests or diagnostic screenings, anything like that, because we may have a whole stack of lab results sitting on our desk, but for that one person, they're probably sitting there waiting to know, am I okay? Do I need to change anything? What's going on? So we need to take that into consideration when we are drawing labs and doing diagnostics to say, even if this is normal, how are we communicating that to the patient? And then care should be communicated or coordinated when complex medications are prescribed. So again, we speak this language every single day, right? But when we prescribe a new medication to our patients, it's like a foreign language to some of them. So if a new medication like even Lasix or a blood thinner, are we following up within just a couple of days to make sure that they understand truly how they're supposed to be taking their medication, and are they having any side effects? Were they even able to pick up the medication from the pharmacy, and how can we help with that? So the huddle, I always joke that I could probably make an entire hour-long presentation on the huddle, because I'm a huge fan of what this does for your clinic and the relationships within your staffing. It really is difficult sometimes at first. I don't know if there's anybody on here that would like to share that they do team huddles or anything like that, but I'd love to hear how you guys, if you're huddling. It was really hard in my practices to implement these, because it kind of got more to what do you have for dinner last night, or what are you guys doing this weekend, or oh my gosh, look at this video of what my dog did, and that type of thing. So I had to structure it, and that's so important. It needs to be efficient, it needs to be consistent, maybe using visuals, including all of your staff. This is a team event or a team action, so it identifies whose role is what, and everybody appreciates those roles whenever they're communicated as a group. But I did have to develop a checklist, and this is just a quick view, but you can see here, we put the date, the start time, the end time, who all was in, everybody just initialed who all was at the huddle. We review our schedule, determine any special needs for the patient. So I'm going to go into this just a little bit. So I blame my mother for this. I will admit, she wrote a lot of my book reports and a lot of essays that won me some different awards or titles or whatever, but she was pretty much an acronym queen, and she always sang silly songs. So that's how I remember things, and that's kind of what makes sense to me. So I developed this, did you brush and floss this morning, to remember things that we needed to talk about in our huddle. So making sure that everyone is on time, be on time, review the schedule, any cancellations, any extra availability or gaps that we can fill, any ER or hospital follow-ups that are coming in. Do we have those records? Use staff wisely. Are you reviewing roles? Do people know what they're responsible to do today? Who's training? Who's doing callbacks? Who's discharging? Any special needs? So patients that are coming in, are there interpreters that are needed? Service animals, any problematic? I will tell you, my mother-in-law, I have I'm blessed with the best mother-in-law, but I would not want to be her doctor because she takes a whole lot of time in the doctor's office. So Linda is her name. Is Linda coming in today? Oh, it looks like we've got that slot double booked. Maybe we need to move her to, just after lunch or something like that. So, and then any health screenings, who needs a PHQ, a depression screening, who needs labs, that type of thing. How's everyone feeling today? Is anyone feeling icky and needs to leave early or coming in late? Is anyone out all day? How will we cover that staff shortage? Support one another, and then end on a happy, success depends on how the day begins. So I always think about a huddle on a football field. That's what this really at the end should look like is, hey, good job, guys. We're going to get out there and we are going to kick tail today in this clinic and we are going to take care of our patients. And so ending on that really good note is important and it sets the tone for the day. So again, I could probably talk about this for a very long time, but I would love to share that checklist with you, the huddle. I've got lots of great huddle tips. So if any of you are interested in how to implement a huddle in your clinic, I'd be more than happy to talk to you about any of the things that we talk about today. So I want to apologize and warn you just a little bit. There are a couple of transitions that are not very smooth, but how this PowerPoint is set up is based on our standards. So we just talked about care coordination and that team approach, which includes the huddles. The next standard talks about care plans, but we've renamed care plans to patient-centered health improvement plans, PCHIPs. So I'm going to use PCHIP and care plan interchangeably whenever I talk about this, but just know, I think that patient-centered health improvement plans or PCHIPs just sound a little bit less sterile. I think about nursing school and the trauma that I incurred during nursing school doing care plans. This just sounds a little bit better and it makes it really more focused around the patient as opposed to the diagnosis. So what is a PCHIP? It's a plan of care and support that is unique to every patient and their needs, is culturally and linguistically sensitive. So are we really asking them how would you like for us to communicate with you? It addresses social determinants of health. It respects the patient's goal for optimal well-being. So PCHIPs, for our standards, not every patient needs a patient-centered health improvement plan or a care plan. Really what we want to see happening in your practice is that you have identified in a policy, actually is one of the things that we require a policy for, but you've identified a certain population within your practice that needs just that extra TLC, that extra layer of guidance and instruction and support with this care plan. So we've seen a lot of different examples for PCHIPs. A lot of practices just say only our patients that are in our chronic care management program need a PCHIP. We see patients that have 2 or more diagnoses, chronic conditions, have a PCHIP. We see patients that have been diagnosed with diabetes in the last 12 months require a PCHIP. I love that one because it is very specific, but it's very effective. We all know how complex diabetes can be, especially to somebody that's new to the diagnosis. There's so many things to keep up with eye exams and labs and foot exams and all the different things that are required and necessary for that diagnosis. So it is what you say it is. It's the population that you've identified. It's not the population we identify. It's who you feel need that extra layer. So what are the components of a PCHIP? I'm going to use an example of maybe a patient that is a heavy smoker and really would like to quit smoking. So of course, every patient, a goal needs to be measurable because you don't know if you're making progress if it's not measurable. So for instance, if a patient wants to quit smoking, maybe they smoke 1.5 packs a day and they want to decrease their smoking to 1/2 pack in 3 weeks. Let's use that as a goal. Well, what are the barriers to that goal? Well, I work with a large group of people and all my buddies go out and smoke together. And so it's going to be really hard not to go on breaks and want to smoke. Well, okay, what are the interventions to those barriers? Let's talk about this. Maybe instead of going out with that group of smokers, you could take a walk around the block or call a support person or a loved one or listen to a podcast or a TED Talk. What can you do in place of going out with all of your friends to smoke? Outline that support system. Who are the people that you're going to contact when you're struggling to make your goal? And then these are also things that are important. So when they leave with their care plan, they should have that in hand. or maybe it can get mailed to them. But a good care plan is also not going to just include their goal, their barriers, their interventions, or support, but an updated medication list that they can refer to so that there aren't medication errors. Diagnosis and symptom management. So if I have COPD or asthma, I know here are the things that I need to do before, I can use this medication, or I can try this intervention before I call the doctor or before I go to the emergency room, right? Community and social services that are available to the patient in their area. Any upcoming appointments that they need to make sure that they have on the calendar or keep. And then how to contact the clinic during and after business hours. So if I get ill or if I start having exacerbations and I know that the office is closed, what do I do? Do I just go to the ER? No, we don't want the patient just going to the emergency room, right? We're trying to reduce cost, prevent those exacerbations. So they should have the availability to contact, and we're going to talk about that in just a second, their provider, even when that office is closed. So this is just a little more elaboration on how to set goals for how to help patients set their own goals, right? We should not be setting goals for the patients because their goals are not going to be our goals. We may think that the patient needs to lower their A1C from 11 to 7, obviously, but how does that translate to the patient so that they can be engaged and successful? Well, maybe they drink 3 sweet teas a day and their A1C is super high. So maybe they just need to drink 1 sweet tea. So that's a great goal. Maybe their goal, maybe they're healthy and they just want to stay healthy. Or maybe they want to play with their grandchildren more. Or maybe their goal is that they want to be well enough to walk their granddaughter down the aisle when she gets married or run a half marathon. So these are just some examples and things to start thinking about. We may think that the patient's goal should be this, but what does it really mean for the patient? Okay, so patient education is one of the next standards. We want each patient when they leave your clinic to be just a little smarter than when they entered that clinic. So at every visit, patients should leave with a little nugget of knowledge. So it could be either about their care plan, how are they going to meet their goals? It could be about a new medication, about their diagnosis. It could be about healthy eating, whatever that looks like for your individual patient, but it needs to be in the EMR that there was education given. It does not have to be a structured field in your EMR, so you don't have to go out and purchase a big application or an add-on to your EMR to meet this measure. It can simply be narrated in your provider note or in your nurse's documentation that education on smoking cessation was given or healthy lifestyle pamphlet was given to the patient. It's important to make sure that that patient understands what they discussed at that visit today. And if there's anything you can give to them that will help them be more, I hate to use the word compliant, but adherent and understand their plan of care a little easier. So advanced access. I want to back up just a little bit with this one because I want you to really understand the whole purpose of the patient-centered medical home model is to keep our patients happy, healthy, out of the emergency department, develop better relationships with their clinic staff and their providers. I like that, relationships are what heal people. It's not our transactions. It's not that, it's the relationships that are built within that team. So again, the whole concept behind patient-centered medical home is taking care of the patients so that they are not getting sicker and utilizing the ER. So that's what really the advanced access standard talks about is how can we provide same-day appointments for urgent illnesses so that they aren't, well, you don't want to lose the business, first of all. So we don't want them going down the street to the next clinic that can work them in, but they should be able to have same-day appointments for those urgent illnesses so they're not going down the street or utilizing the emergency department. Evidence of expanded weekday, evening, and or weekend appointments. We want to see here just something outside of that traditional Monday through Friday, 8 to 5. So if there's a working mom or maybe even a student that's in school that needs to be seen, they don't have to miss school or miss work. So maybe offering a 7:30 a.m. appointment a couple of times a month, or maybe staying open until 6 o'clock a couple of nights a month, or we see Saturday clinics occasionally. So we really don't dictate how those expanded hours truly look. We just want to know that you are doing something for your population outside of that Monday through Friday, 8 to 5. It could be 2 to 4 days a month that you're expanding those hours. Again, we just want to see that that's happening and that there's some effort being put into that based on your patient needs. And then call coverage. I touched on just a little bit, but what kind of call coverage, or how can I, as a patient, reach my provider or the provider that's on call for my provider after hours? So are you able, and if you're doing chronic care management, this is also a requirement for CCM. A nurse line is great as long as that nurse doesn't just say, oh, I can't give you advice over the phone, you need to go to the emergency room, right? Or you can't have, of course it wouldn't meet the standard if you had a recording on your after hours voicemail that said, you've reached the office after hours, sorry, our office is closed, please go to the emergency room for all needs. Of course, we don't want that to happen. So there should be something on the recording or something posted that says, for after hours needs, please dial this number. And the provider who is, your provider or the provider who's on call will be in touch with you as needed. So that's kind of a hard one to meet a lot of times in rural, but there are some ways to work around it. And there are some great services that are available out there. I'd love to give you some connections that are not, they don't cost an arm and a leg. So I think this is an interesting statement here. The US could save $67 billion each year if everyone used a primary care provider as their principal source of care. So every $1 increase in primary care spending actually produces $13 in savings for the healthcare system. I think that's pretty significant. So some patients just don't understand. Some think, oh, the doctor's office is closed, so at least there's an emergency department that's out there available for me. Or, oh, I missed my appointment this morning because I overslept, or I didn't get off work in time, so I'm just going to go to the emergency department. Some people just don't understand the logic behind why they shouldn't use the emergency department for primary care. And so educating them, making sure that they understand this is when it's appropriate to see your primary care provider. And this is when it's appropriate to go to an urgent care, and this is when it's appropriate to go to an emergency room. So teaching the patient about that appropriate use could be helpful. We're kind of at a midway point right now, so I want to stop and make sure. Danae, are there any questions, or does anyone have any questions or comments they'd like to make so far about the content we've covered? Take a drink too.
We don't have anything in the Q&A or the chat right now, but we can give it just a moment to see if any come in.
Okay, I'll go ahead because I do have quite a few more slides to cover. Like I said, we're about halfway, so I'll go ahead, and then please feel free to interrupt me if there are questions that come in. So the next standard talks about complete patient health records. So those of you that are, you get surveyed, right? Everybody gets surveyed in your rural health clinic if you're getting paid by Medicare. You know that there are certain components that are required for RHC accreditation or for certification. And those are things like consent forms and the normal typical stuff that are pretty black and white. Well, for patients in our medical home, there's a few more requirements when we are looking at your charts. We want to know that you are asking patients if they have an advance directive or if they're interested in one, specifically for patients over 65. Of course, you have a healthy 25-year-old come into the clinic, you're probably not going to ask them if they're interested in an advance directive unless there's a reason behind that. But 65 and older, we like to see that you're addressing advance directive status. And if they don't have one, are you offering any kind of information or education or an additional appointment that you can actually bill for advanced care planning? Depression screenings. We feel it's important that every patient over the age of 12 is screened at least annually for signs of depression. So we hear a lot of times that clinics are only doing depression screenings if the patient has signs of depression or brings it up. That's sometimes too late. So you should really be screening everyone over the age of 12 for depression, because they may just not bring that up, or they may not want to talk about it. Cognitive screenings. This is also another one for 65 and older, unless there's a reason, that it might be appropriate for younger than that. But we want to see that each patient during maybe their annual wellness visit, or it doesn't have to be during the wellness visit. That's just what we see most commonly, are getting either a mini cog, or there's several different standardized tools that you can use to assess for cognitive decline. We want to see this is happening annually for 65 and older. Preventive health measures. So are we looking at things just beyond their acute maybe visit, or their sore throat, or their backache? Are we talking about you have hypertension, so we need to make sure that we're getting your cholesterol panel regularly? Are we for diabetic A1Cs? Are we doing wellness visits? Are we referring patients for colonoscopies, mammograms, all of those things? A needs assessment. So this is something we want you to be considering for your population to assess and address for social determinants of health and things outside of just their physical well-being, but their mental well-being and their social well-being and their home safety type of things. Patient goals. So like I said, in when we were talking about the P-CHIP, not every patient needs a P-CHIP, but every patient should have a goal, right? There should be a goal that they're working towards. So like I said, it could be that healthy person just wants to maybe run a marathon, or that grandmother just wants to attend her granddaughter's college graduation, whatever that looks like, but each patient should have a goal. Lab and diagnostic follow-up. We want to make sure that those loops are being closed. So when there is a lab that's ordered, that result should be in the chart, and then you should have documentation that shows patient notified of this result. After visit summary and instructions. This is a really important one. I'm going to throw my poor husband under the bus for this one. Boy, I'm just my family. It's a good thing they don't listen in on these webinars, isn't it? But an after visit summary. So I'll give you this example. My husband has multiple sclerosis, and so he goes to the doctor maybe once or twice a year. When he goes, he comes home if I can't make the appointment with him, and I'll say, hey, how did it go? Anything new? Nope, it went great. Nope, he said, I'm doing great. And then before I know it, he's headed off to the pharmacy or to the lab or something. And I'm like, I thought you said nothing changed. What's going on? So he's smart enough now to provide his nurse wife with an after visit summary that says, here's what we did at this appointment. And it clarifies things. So, you think about whenever you go to the doctor and you're not feeling well and you hear about every third word the doctor says, because you're just like, just give me my medicine. I want to go home. So if patients have that after visit summary and they know what happened at that visit, then they can refer back to that or hang it on their fridge or give it to their wife to make sure that there are no errors in adhering to that plan of that whatever was discussed at the visit. So that is a requirement for each visit for every patient. Let me go back to that just for a second. For after visit summaries, it can be printed and handed to the patient, or if you can show that they are accessing it through the portal, that's also a way to meet that measure. So kind of switching gears into social determinants of health. I like to ask this in person because I like it whenever people just yell out numbers, but what percentage do you guys think of a person's overall health is determined by what we do in the clinic, by what happens in the healthcare setting? A lot of times I get 50%, 60%, 70%. Well, I hate to tell you this, but only 20% of what we do in the clinic actually affects what happens to their overall health. 80% of what makes up someone's health is determined by what happens in their home or their living environment, their social factors. So I think that that's very interesting. And so that's why we have a standard that talks about assessing and addressing patient needs from a whole person perspective, not just from a stethoscope perspective. So this is a screenshot of one of the needs assessments that we have available as a tool on our website to assess physical health concerns, mental health concerns, their personal concerns, so any social determinants of health, transportation, access to nutritious food, things like that, safety in the home. And then it's also a place to get their brains kind of turning and thinking about, what are my goals? Because if you've ever sat down with a patient and interviewed someone and said, what's your goal? They're going to go like a deer in the headlights. I don't know. Help me think of something. Give me some ideas. So this is just something that, some common goals that you hear and see and gets them thinking about how they can work towards better health. So who gets one? Every patient really should be assessed and addressed, or their needs should be assessed annually or so. And that's really something that should be built into a policy of yours, is how often you do a needs assessment for your population. And is staff trained on how to assess and address those needs? Because that's a big thing. So we want to see that your staff has some sort of training about social determinants of health and health equity. And then what's your follow-up? What good is a screening if there's no follow-up or there's nothing that happens behind it? You may find out that a patient doesn't have access to food or to healthy foods, or you may find out that they have no way to pick up their medications. But what are you doing about it? Are you able to hook them up with community resources? or behavioral health or an insurance enrollment specialist or whatever their needs really are. So utilizing patient satisfaction surveys are a great way to figure out what do I need to do next? What are some quality improvement things we need to be doing? Let's get the perspective of the patient to see how we can improve how we're providing patient care. So we want to know that you are collecting patient satisfaction surveys. And one of the great things that we offer is a platform. So it's free to all of our clinics, RHC, PCMH, but we have a platform that takes the place of or complements Press Ganey or CAPS, any of those, but it's free to any of our clinics. And if that's something that you're interested in looking at, let me know. It's a great platform. I used it for all of our clinics, and we were able to see national results. So we could compare to all of the national results. We could print out. I had a great printout. So I'd be happy to talk to you about that as well. So what are the benefits to the patient? We've already talked about this a lot, of course. The biggest one is having those relationships and getting in and knowing the patient and letting them know, hey, we care about more than just the antibiotic we prescribed you. We really do care about your outcomes and we want to keep you healthy. And we want you to come into our clinic and feel like this is your home, your patient-centered medical home. So providing those same-day appointments, that care plan that lets them know exactly what they need to do. Having after-hours call available, either a triage service or an on-call service or a call rotation between your providers. Implementation of the team-based approach to coordinated care and assigned a care coordinator who develops those relationships. A little bit of redundancy, sorry about that. So staff satisfaction. By getting these things in motion, you're promoting your staff to work at the top of their license. So one of the things that we implemented in my clinics were standing orders. So when a patient with, let's just say again, diabetes came in, we had a standing order that said, okay, this person has a diagnosis of diabetes. We know that they need to have this, this, and this. So then when the provider came in, all of those things were already taken care of. Those labs were already ordered. That referral was already sent to the referral coordinator to process. So having those things out of the way so that the provider can truly build those relationships and get done what needs to get done. So that improves, staff feels more empowered. Providers have time to do what they need to do as opposed to clicking and ordering things that are so, just routine. We like to see those outcomes. It's really nice to actually get to see your patients get better or those ER visits decrease. So there's a lot of ways that staff can become more satisfied with this model. Benefits to the practice. So what are payers looking for? They're looking for everything we've talked about. They're looking for improved outcomes and lower costs, right? So PCMH is the foundation for our value-based future because payers are really starting to take notice of this model. A lot of payers, a lot of states actually already have a per member per month for clinics that are a patient-centered medical home. So I think that there's a lot, like I said, a lot of movement in Louisiana for this. So it really is the direction that healthcare is going. So here's just some testimonials. Danae's going to supply you guys with this recording and my PowerPoint. So you'll be able to read these. I'm not going to just sit here and read testimonials to you. That would bore you and you'd go to sleep over your lunch break. But what does the preparation look like? It's pretty simple. I would say that a clinic can transition and get ready for survey within 3 months. So what that looks like is you get assigned an advisor. Sometimes that's me. Sometimes we've got 2 or 3 other advisors. And we go through each of the standards. We comb through them with you. We let you know what is truly expected, that interpretive guidance and what policies are required, what we expect to see when we come on site. So after you go through all of your advisor calls and we've got all of your questions answered, then you let us know when you're ready for survey. And we come on site and it's so cool because we get to listen to all of the extra things that all the lanyap. We get to hear the lanyap you're doing and you're providing for your patients. And you get to tell us about the diabetic programs that you're running. And you get to tell us about all of the different things that you've seen with your patient population improving. And we'll look at 10 charts per clinic to just look for those components that I talked about earlier, the advanced directive and things like that. That's it. So typically we can get a clinic ready to roll within, I would say, 3 months. Okay, so that is all for PCMH. I know that took up 3/4 of our presentation, but it's for a purpose because it lays the foundation for everything else we're going to talk about. So chronic care management, I'd love to be able to know who on the call is actually providing chronic care management services for your patients and billing for it. You're doing this work. So if you're not getting paid for it, if you're not billing for it, you are missing out. So it is 20 minutes of non-face-to-face time that you're spending with your patients that have 2 or more chronic conditions in Medicare. Think about that. Just kind of reflect on some of your patients that you are on the phone with a lot, or that you're setting up referrals or doing those things outside of the visit. So any time that is spent outside of your 15-20 minute encounter in the clinic can be billed, can be tracked and billed. So, CMS actually originally patterned this program for patient-centered medical homes because they're so already set up for it. They already have the after hours thing. They already have the care plan in place. So it's the foundation for that. But if you are not doing chronic care management, I've got a really great starter kit that if you want to have a conversation about getting that implemented in your clinic, I can provide you with some great tools and guidance. We were billing, I think whenever I left our clinic, we had our clinics. Of course, we have 12 clinics, so you got to think about that. But we were billing about 1,700 chronic care management encounters a month. Here are the finance. Oh,
we did have someone come through and say they are doing CCM at their clinic.
Good deal. Congratulations. That's great. I hope everything is going well. I know it can be kind of tricky getting started, but good. You're on the right path. Congratulations. Okay, so these are the financial rewards, just at a glance. So you can see if you have 50 patients in your practice that have Medicare and 2 chronic conditions, there's $4,000 a month. So if you were sitting there thinking, how are we going to provide care coordination? How are we going to be able to do all of this thing? Here's how you can fund your care coordination program, your PCMH. Like I said, 50 patients would be about $4,000 a month, and then it just goes up. Just so you know, G0511 is the only billable code for chronic care management and principal care management and BHI. So that G0511 is actually an umbrella code for a lot of the things that are provided. So G0511 is the only CCM code that you can bill for out of an RHC. So moving on to pay for performance initiatives. I used to meet with my payers, our Humana reps, our managed care plan reps, all of those people at least quarterly. And I would say, here's what we're doing. We're a patient-centered medical home. Here are the initiatives we're working on. How can you help us? What are some incentive programs that we can participate in because of the work we're doing? Or what are some of the incentive programs that you offer? But sit down and make some, kind of maybe prioritize it based on your largest payer source in your clinic. But sit down with them and say, here's what we're working on. Here's what we're doing. What are some of the incentive programs or some money that's out there that's available for us for taking really great care of our patients? Another tip, I'm going to wrap this up pretty quick, but another tip is to look into what incentives are out there for your patients. A lot of times, if you're struggling to schedule those wellness exams, payers are going to incentivize them sometimes up to $50 for that visit. So when you're scheduling those appointments and trying to get your patients to come in, if you just knew, if you had a cheat sheet, I created a cheat sheet for all of the different incentives for patients. When our receptionists were scheduling those, we could say, hey, you have Humana, they pay $50 for a wellness visit. So let's get that scheduled for you. Quality improvement. I would say, I'm not going to elaborate too much on this, but identify some things in your practice that need to be improved, but don't identify 15 things in your practice that need to be improved. Obviously, that's great if you are, but what I found was so impactful was having 1 per quarter. I would look at something that I felt was very important for our patient population or our staff or our clinic in general or our community. And we would focus on that one thing and we would improve that one thing and make sure that that process was solid. And then the next quarter we could look at it and go, we could use a little more work, or, hey, we knocked that out of the park. Let's start a new initiative. But having that focus and engaging your staff in those quality improvement efforts, it can be fun. I know it sounds silly. It shouldn't just be you managers or you administrators at the top identifying those things. Work with your clinic and say, your MAs and say, why do you think that we can't get why is our average A1C so high? Or what's going on with patients' medication adherence? Why do you think they're not taking their meds? And then working on a plan to improve those. Here's just an example of a policy, or I'm sorry, not a policy, a template that we do have available again on our website for process improvement. So you can see at the top, you identify the indicator, the measure you're wanting to improve. Here's your baseline. So I'll use no call, no shows as an example. We did this one quarter. We identified that our no call, no show rates were like 28% in one of our clinics, which is crazy. I think the national average is about 18%. And so that's what we set our goal at. I think we set our goal for 17%. Why is this important? Well, that's, you can elaborate on why that's important. What are we going to do? Who's responsible for these tasks? And then you look at the end and say, here's our end result. Did we improve the way we wanted to? Do we want to adopt this test and keep going and make it part of our everyday practice? Do we want to adapt it and maybe repeat it for another quarter? Or do we want to completely abandon it? It was a flop. We got to start over. So just a good one-page worksheet to do and to show what type of quality improvement efforts you've been working on. Wellness exams. I had this in every single one of my clinics. I had this little index card at the front desk. If you don't make time for your wellness, you'll be forced to make time for your illness. So getting patients to get those scheduled, there's a lot of benefits. I don't know if any of you are participating in ACOs, but I'm sure if you are focusing on your annual wellness visits because it's a huge push. It's a great place, a great focal point to get those depression screenings done, those cognitive assessments done, needs assessment. So it's a great opportunity to get all of the things outside of that acute, when patients come in and they're not well, they don't want to do those screenings. They don't want to talk about those things. So doing this in a wellness visit is great. Unfortunately, not all the work that's done within those wellness visits have to be done by the provider. That's a big barrier sometimes. Providers think, I don't have time for these. Why would I do a 40-minute annual wellness visit whenever I can do 2 or 3 99213s and get paid for those 3 visits over that one? Well, have an annual wellness visit person or nurse that can come in and get 75% of the work done before the provider even steps in the room. So there are some workarounds, but just know that not all the work and not all of the things that have to be done within that wellness visit have to be done by the provider. So just to recap, and then hopefully we'll have a couple minutes for questions. Hopefully you took away something and you're like, I'm going to do that. That's the next thing I'm going to do on my list. So whether that is talk about patient-centered medical home accreditation, talk about implementing a chronic care management program, meet with your payers, starting a quality improvement project today or tomorrow or next week after the holiday, working on huddling with your staff. That's a great place to start too. Just getting your staff together in the mornings and making sure everyone's on the same page and making your day run more efficient. Or how are we going to start focusing on wellness visits? So hopefully everybody that listened today has a takeaway and has a plan for what they're going to do next. We have lots of resources. I talked about those throughout the presentation. We're here to help. There's lots of tools and guidance and individual advisors that can help you, whether it's with RHC questions or PCMH questions, quality improvement guidance, whatever that looks like. We have a swing bed. I just want to mention that we do have a new swing bed certification for those of you with critical access hospitals. And then I would be happy to answer any questions either through the chat or virtually. As you see here, my email is there. And then also that's my cell phone number. So feel free to call me on that. It happens all the time, but email is usually the easiest way to reach me. And then are there any questions today that we see so far?
I don't see any just yet, but we can give one more minute. We have about 4 minutes left in the webinar, so we can give a minute in case anyone's typing some questions in.
Wonderful. So I did find, for those of you thinking about chronic care management, just a little story, a little testimony. A few years back, probably like 2016, whenever rural health clinics could actually start billing for CCM, we really tried hard to get that program up and running, and it felt like we just couldn't find our rhythm and we were chasing our tail with CCM. But once we became patient-centered medical home, like I said, and got all of those other things, those processes and those policies, and identified staff who is responsible for certain activities, then our chronic care management program just took off. So I think that would be a great conversation to have if any of you are interested in getting either or both of those programs up and going. I would be happy to talk to you.
We did have a question come through.
Okay.
Regarding the patient satisfaction survey portal, do we have to be signed on with the compliance team PCMH program?
Not necessarily with the PCMH program. You do have to be our client. So if you are one of our rural health clinics and we offer you that rural health clinic accreditation, then you will have a login, but you do have to have a login, and you won't have a login unless you are one of our customers. Yes.
She said they are a client. So
Then, yep. If you want to look me up after this, I'd be happy to set up a little tutorial of that. We call it our patient quality measure portal. So I can give you a little tutorial of how to start using that. I'd be happy to.
all right. Yep. So she'll do that. Kristen's email's there on the screen for you, Nicole, if you want to just grab that and you can reach out to her afterwards.
No, I know Nicole. I was wondering if that was Nicole Simon. I know her. Good deal. Okay, well, maybe you guys can have just a couple of minutes back for the day. If there's any other questions and you need to get a hold of me, feel free to contact me anytime.
All right. Well, good deal. Thanks so much, Kristen, and thanks everyone for joining us. As a reminder, as you exit out of the webinar, you should get a brief survey. It'll pop up in your internet browser, so please do take that for us. The recording will be available on our website within the next couple of days, and you'll get an email again with that link, and the link is also in the chat. So, and as always, please feel free to reach out to LRHA if we can be of any assistance. You have Kristen's information if you have any additional questions about PCMH. And thank you so much and have a wonderful afternoon.
Thanks, Danae.
Thanks.
Bye.